Alrighty, everybody. Hopefully this is the final actual thing you have to do before the true end of your night, okay? Hello and welcome everybody to tonight's program. A special welcome to our virtual attendees watching via the Medscape Connect platform. We invite everyone to join the Medscape Live Connect platform by scanning the QR code on the front of your agenda at your seat. For those of you all that are remaining, joining the platform is the method to ask questions, follow the slides, and really participate in the polling. We really encourage the virtual audience to ask questions and participate in the polling as well, okay? So we're really looking forward to this next session that's going to be focused on the therapeutic evolution of metastatic hormone-sensitive prostate cancer, or as of today, APMS, okay? Androgen pathway modulating sensitive, androgen pathway modulating resistant. You're going to start hearing a lot of us utilize those terms as we evolve our nomenclature. So we're going to be analyzing emerging combinations and outcomes, okay? So here we kind of reviewed this. Here's the Wi-Fi network, Medscape, and the password you can see here. You can use your own technology device, your phones, iPads, to connect and follow through. Here's the QR code, okay? Alrighty, so we're going to dive right into the therapeutic landscape. I am honored to be moderating this evening's session. Raina McKay, I'm a GU medical oncologist at the University of California, San Diego, with my awesome, esteemed colleagues, Dr. Alicia Morgans at the Dana-Farber and Dr. David Morris at Urology Associates PC. Welcome so much. It's so great to have you. And I was commenting, David Morris probably has the greatest shoes that you've seen at the entire meeting, and I want them, and I want to buy 5 of them for me and my kids, okay? Well, they're so cool.
They're very cool.
Aren't they cool? They're kind of awesome. Okay, so here's our program agenda. Intro, we're going to go through the pivotal clinical data analytics. Dr. Morgans is going to take us through that, then clinical considerations to enhance your practice. Dr. Morris will take us through that, and finally, closing remarks and Q&A, okay? Alrighty, so the treatment landscape for metastatic hormone-sensitive prostate cancer, just to level set, this is global data of the age standardized rates. Prostate cancer is a very common cancer globally, the second most common cancer globally, and it's a very common cause of cancer death. In the U.S., the leading cause of cancer mortality among men, second leading cause of cancer mortality. And so, as we think about the clinical course for prostate cancer, the majority of individuals actually present with localized disease. And actually, for most men, they are cured with local definitive therapy, whether that be surgery or radiation with or without hormones. But a subset of individuals do go on to develop a biochemical recurrence. And some of those individuals do go on to develop metastatic hormone-sensitive disease. And there are a subset that present right off the bat with metastatic disease right from the get-go and don't necessarily have a history of localized disease. And then the emergence of mCRPC is a universally lethal disease with a life expectancy based off of real-world data that's about 2 years. I think some of the clinical trial data that we've seen data push up to 4 years, but it is a universally lethal condition. And the M0 CRPC setting is just increasingly dwindling down with the advent of PSMA PET imaging, where we are actually seeing stage migration and identification of metastases at a sooner onset. And this is another spectrum, sort of like temporally thinking over time. Primary therapy, PSA here is on the y-axis, and then at time of recurrence, treated with different, androgen deprivation therapies, the androgen pathway modulating treatments, and the emergence of CRPC. So we've seen an evolution of the treatment over the last decade. God, I can't believe it's been almost a decade from when Charted was presented in 2015. And we moved away from ADT as a monotherapy and treatment intensification in the mHSPC setting. So first starting off with the addition of docetaxel and then building upon that with the ADT ARPs. Actually, all of the ARPs now, including abiraterone, apalutamide, enzalutamide, and most recently, darolutamide. And because the backbone changed from ADT mono to ADT docetaxel, we've also seen the emergence of triplet therapies with ADT, dosi with the addition of an ARPI, both from PEACE-1 and also from ARASENS, demonstrating the benefit for triplet therapy over the backbone of ADT docetaxel. So this is sort of the foray of all of the really landmark studies that have been presented. I want to highlight this meta-analysis that was done with individual participant data from 7 key clinical trials demonstrating an OS benefit to ARPIs in the metastatic hormone-sensitive setting. You can see the hazard ratios across these trials ranging from 0.59 to 0.86, really across the board, and an overall hazard ratio favoring combination therapy with a hazard ratio of 0.66. So truly demonstrating a benefit. And as I present this slide, it's actually really great to see the movement away from ADT monotherapy. This is real-world treatment patterns in the U.S. showing decreasing use of ADT monotherapy. That's highlighted in the royal blue. And I know the numbers for 2024 are small, and I think data continue to emerge, but rates are certainly declining. Rates of ADT ARPI utilization are now exceeding 50%, not exactly where they all need to be, but exceeding 60% is great. The rates of triplet therapy utilization in this cohort is around 20% in the modern era. I think other real-world data sets have demonstrated utilization at the 10% or just under 10% mark. We're still seeing a little bit of ADT docetaxel. Need to tease that out because technically that's no longer a standard of care in any setting, but there could be insurance issues that result in us seeing those modifications. And then here is sort of a bird's eye view of treatment recommendations in the mHSPC. This is not really for you all to go through every single one of these line items, but AUA, CUA, EAU, NCCN, ASCO, ESMO with the level 1 evidence guidelines around the different indications and different treatments. Again, as I stated, there is a movement away from ADT docetaxel as a treatment in and of itself. And I think in the context where somebody may not have access to an ARPI, that certainly can be considered, but really the standard is ADT ARPI versus ADT ARPI docetaxel. All right. And so this is sort of the way I like to kind of think about things, at least right now. And this will continue to evolve as we have biomarkers, BRCA status, PSMA PET status, and different emerging therapies. But I think for this moment, breaking it down by de novo, synchronous, metachronous disease, and then high volume, low volume, you can see for the de novo patients, really the treatment options are ADT ARPI, ADT ARPI dosi, and then for those patients that have low volume disease with an intact primary, considering radiation to the primary. And then for the recurrent patients, ADT ARPI, and really for both high and low volume disease. And the choice of ARPI is really dependent on multiple factors. Again, what you don't see on this slide, there is no box for ADT monotherapy. There is no box for ADT docetaxel. So really the decisions are around ADT ARPI and which ARPI, or triplet therapy with ADT ARPI docetaxel. All right, and so just to kind of level set when we talk about different definitions, high risk and high volume disease are not exactly the same thing. The high risk definition evolves from the Latitude trial and involves 2 of the 3 of the criteria that you see here of Gleason score greater than or equal to 8, 3 or more bone mets on a bone scan, or the presence of visceral metastases, so having 3 out of those, or 2 out of those 3. And then high volume, that's from Charted, based off of either the presence of visceral metastases or 4 or more bone mets with at least one of those that's outside of the vertebral column or pelvis. So there is about an 80% overlap in these definitions when we look at concordance, but there's 20% of patients that meet one definition but may not meet the other. Okay? And just to talk a little bit now about mechanisms of resistance to anti-androgen therapies, I like to very simplistically break this down into what are AR-driven mechanisms and what are non-AR-driven mechanisms. And I think these tumors are very smart, and a lot of our therapeutics are actually continue to be geared at targeting the AR pathway. So there's AR amplifications where you can just make more copies of the androgen receptor, or the androgen receptor can mutate and different ligands can then bind to the androgen receptor. You can have co-activators or co-repressors. Sometimes the tumors can actually make its own steroids or androgens to bind to the androgen receptor. And then there are non-AR mediated pathways, whether they include cytokine pathways, tumor growth signaling pathways, emergence of lineage plasticity, beta-catenin signaling, cell cycle, those other pathways. And then again, this is kind of a nice breakdown, and I like this because I think it's really exciting time to be a genitourinary medical oncologist, radiation oncologist, urologist, because there's so many active drugs with novel mechanisms of action that are being tested, and a lot of the drugs that we see now that are in phase 1 through 3 testing are actually targeting many of these pathways, and it's really exciting to see the therapeutics emerge from a better understanding of the biology. So this is not to learn everything on the slide, but just a bird's eye view of mechanisms of resistance. All right, so with that landscape, I'm going to turn it over to Dr. Morkins to take us through the pivotal clinical data.
Thanks, Dr. McKay. All right, so let's talk about treatment intensification. I think this was alluded to certainly as Raina was talking through the different guidelines and really the evolution of our ability and interest in combining multiple different things with ADT. No matter what you combine, in most cases, you're going to have a benefit. And so just to remind us, we mentioned CHARTED very briefly. This was the first study of chemotherapy in combination with ADT that actually showed, and it was very surprising at the time, that if we added chemotherapy in that early state, we could beat ADT alone and in prolonged survival, particularly in people with high volume metastatic disease. And you can see here, this is just a meta-analysis of these 3 studies, all looking at the addition of docetaxel to ADT versus ADT alone, demonstrating that docetaxel is better or ADT, docetaxel is better than ADT alone. And here we have the OS benefit as well demonstrated. When we think about docetaxel and in terms of its PFS and OS benefit for our patients, I think we do think about those different states that Raina also mentioned, whether the disease was treated before and has recurred, metachronous disease, or whether this is de novo metastatic prostate cancer that is by its very definition telling us that it is a more aggressive phenotype. We also think about low volume and high volume, with high volume being a more aggressive phenotype typically, and that's why this is part of that treatment algorithm that she was talking about. And why do we make those decisions on that treatment algorithm? Because of analyses like these that help us understand that when we are able to intensify in a more aggressive disease phenotype, we can actually have even more bang for our buck. So when we have synchronous disease or de novo metastatic disease that is high volume, this is the most aggressive phenotype with the shortest expected overall survival. If we add docetaxel to ADT, we can have perhaps the biggest benefit in that setting. When we have recurrent disease that is low volume, this is probably our best prognosis, and these patients actually may have a long survival and may not need docetaxel, but they do seem to have some of the biggest benefit from an ADT ARPI intensification. So breaking things down this way, I think, is really important in our clinical decision-making, and it's based on data like this that demonstrates that favorability, particularly in the most aggressive phenotypes. So as we think about the takeaways here for docetaxel and ADT showed overall survival benefit as well as PFS survival progression-free survival benefit versus ADT alone. But as Dr. McKay said multiple times, ADT docetaxel is no longer a standard of care, is no longer listed as a recommendation on the guidelines. If a patient can tolerate docetaxel with their ADT, we should be adding an AR pathway inhibitor to really maximize that benefit. And the studies that we have suggest that that would be either darolutamide or abiraterone. But we also do have some lower category recommendations to potentially add enzalutamide and apalutamide as well. Combination that you choose needs to be best suited for the patient, with the perhaps triplet therapies being given for patients who have that most aggressive phenotype, high volume disease, synchronous or de novo phenotype. And there's really not no evidence of benefit for patients with low volume or metachronous disease, but I think that in clinical practice, we may see a young patient wishes to be aggressive. Maybe we happen to catch low volume disease early, but this is de novo. These patients can still benefit. Some of these patients, even though they don't fit the exact box, we may still choose to be more aggressive. So this is really where that shared decision making comes in, maybe where genomics and genetic information comes in, and your clinical expertise. But these are the general buckets that we put people into. When we think about triplet therapies, let's dig into this a little bit more. We have PIS1, Arisens, and Enzamet. All of these studies included, in some way or another, docetaxel, ADT, and an ARPI. So when we look at all three of these sort of laid out, these are all registration level studies. Well, Enzamet was not used for registration, but is a phase 3 international trial. These are multi-center. These include large numbers of patients, as you can see here, well over 1,000 patients. And the treatment groups, as an example, PIS1, this was actually a complicated 2x2 design. But in general, this was standard of care, ADT, docetaxel, with or without abiraterone, if we're talking about this context for systemic therapy. For Arisens, we had ADT, docetaxel, and darolutamide versus ADT, docetaxel. And we also see Enzamet in the patients who got, or the group that got docetaxel, ADT, docetaxel, and enzalutamide versus ADT, docetaxel. There are some nuances around Enzamet too that make it a little bit more complicated, but in any event, that's the general randomization to talk about in this context. The primary endpoints here, overall survival, rPFS, and you can see the median follow-up. When we think about this data, we can see the hazard ratios on the right demonstrating that OS benefit, time to CRPC, which is essentially a progression endpoint, for all of these really favoring the triplet therapy, adding that ARPI onto the ADT docetaxel backbone. So that's the main message here. And here we have just the forest plots telling us where is the most benefit, perhaps, in those patients with high volume disease, but low volume patients can also benefit, and that's why it's important to kind of understand that patient in your clinic. And in Enzamet, we can actually see even more of an advantage. Low volume patients actually do have a longer overall survival anyway, so in some contexts can have even more benefit. So let's talk about doublet versus triplet. And again, Raina laid this out in a really nice diagram all the way at the beginning, but to think about their relative contributions. We have many studies that are looking at ADT and an ARPI combination versus ADT alone. You can see Stampede, Latitude, which is looking at abiraterone, both of those, Arches, which is looking at enzalutamide, Titan looking at apalutamide, and Aranote looking at darolutamide. And whenever we add one of these ARPIs to ADT versus ADT alone, we see that there's an advantage in terms of rPFS, and for most of them, OS as well, as we can see on this slide. We could see here also, we can look by different groups, the volumes in general, again, consistent message, add the ARPI to the ADT backbone, and you will beat that in terms of many of these factors. These patients benefit whether they have high volume or low volume disease. They benefit whether they have synchronous or metachronous metastases. And here is just an interesting outline of sort of the relative difference. Now, importantly, we should not be doing cross-trial comparisons and saying this is better than that is better than this, but this is just sort of to lay it out. And the general idea here is that we can have longer, perhaps, survival, particularly when we think about those patients with more aggressive disease when we intensify therapy, all the way down to ADT alone at the very bottom. When we think about these treatments, again, we could think about these patients maybe benefiting the most from ADT triplets with their high volume disease, and just lots of different analyses that really support this. And I guess to ask a question before we move into some ongoing studies in metastatic hormone-sensitive disease, I'm still not quite up on the APMN
APMS
acronym.
and APMR.
I'm trying. I keep using naive instead of sensitive. No. But in any event, when using a backbone, I would love to hear from everybody here. When using a backbone of ADT and ARPI, does the benefit of docetaxel justify its toxicity? Why don't we hear from you as a urologist? You have to send patients over to the medical oncologist to do this, so there has to be a reason for you to do that. Is it important for some patients?
It's definitely important for some patients. I think the real key, and while we're here for a whole hour, is to talk about who are the patients that we should be intensifying in. because this isn't addition of, I mean, the trials haven't been done as addition of docetaxel to an ARPI doublet. They've been done as the dosi doublet with potentially the ARPI added in. And so that's not really the question we're trying to answer in clinic. So it's very challenging. We're extrapolating from the trials and saying like, well, if they look worse, they do better with more treatment. And so I think most urologists are trying to eyeball patients. We're very good at eyeballing for surgery to make sure that it's safe, but it's new to try to identify what are the things that would limit us from giving chemotherapy to this patient. And it is a bit of a sales pitch from a urology perspective and to encourage someone to go get chemotherapy, because we deal with a lot of the hesitancy on the front end, and just getting them often into your clinic takes a little bit of a sales pitch. And then they obviously have to have a sales pitch from you on what the operations side of it looks like. So it's a bit of a challenge. So we do have to kind of get them past the eyeball test of saying, not only can you tolerate it, but is it justified? And it's not really my place to fully educate on what all the side effects are, because that's not really my role, but at least encouraging people to say, you need to hear about this. So that's really my job, is to say, look, I don't care whether you choose it or not, but if you're my family member, I think you deserve to hear why this might be better for you. And if you were in my family, I'd tell you need to go hear from the expert. So that's our discussion on most day-to-day practice, hopefully.
That's great. I mean, Reina, what do you think? Do you find that most people in Southern California want chemotherapy? Do they get chemotherapy?
Yeah, no, it's a very good question. I think patient selection is a huge thing that we contend with day to day. And I think a lot of things, it's really actually trying to understand what are the goals for that patient and what are the values for that patient. Because honestly, you could have this same exact phenotype across 10 different patients, and their tolerance for risk for benefit is very different. You know, some patients are like, doc, give me anything, I'll do anything, even if I'm gonna live one day longer, give it to me. There's some people that are like, I just wanna go on my merry way and kind of see you as little as possible as I need to, and so that tailors our strategy. Yeah. And so I think it's not a decision that we make in a silo. I think it's very much right now a decision where we don't necessarily have level 1 evidence to say do this versus that, and it's a lot of important discussion with patients.
Yeah. You know, one comment I'll also make, I have patients who come just in the first group that you talked about, you know, that patients give me everything, I want everything. There are definitely patients where I have the conversation, you know, you actually probably don't need chemotherapy up front. Yeah. You have recurrent disease after 10 years after your prostatectomy. You have a small amount of disease. We're going to use ADT and an ARPI. Yeah. So it is really tailoring to the disease and also listening to the patient to try to make the right decision here.
Yeah. And I think this really segues into some really critical studies that are being conducted through our cooperative groups that are actually trying to answer that very question that we are all contending with day to day of what is the contribution of docetaxel when we're using the backbone of an ADT ARPI. So here is the schema for the ASPIRE study. This is a randomized phase 3 trial that is open to enrollment through the cooperative groups, basically for patients that have high volume disease or de novo low volume. It is not enrolling patients, Alicia, as you stated, with metachronous low volume. Patients can have enrolled having already started ADT, already started at ARPI, as long as that period is less than 120 days. We're enrolling patients who have an ECOG of 0 to 2 are eligible candidates for docetaxel. And patients are randomized 1-to-1 to treatment with ADT APA versus ADT APA docetaxel with a primary endpoint of overall survival. I think it's really interesting as we've seen data emerge during this meeting, particularly from the GUNS study that was presented by Dr. Martin Gleave about the role of docetaxel in the HSPC setting with localized disease, and we've seen other data emerge from STAMPEDE. For this study, we are doing a stratification factor based off of the presence of tumor suppressor gene loss alterations, whether it be 0, 1, or 2 plus, as well. So I think this is going to be a really important question that's going to answer what we're contending with, and docetaxel continues to be a really relevant treatment in this context. Another really important study is the triple switch study, which is answering a slightly different question. We've all seen data emerge from Stampede, Ironman, other data sets of the old SWOG studies, looking at the benefit of 6-month PSA nadir of 0.2 or under for patients that have mHSPC as being incredibly prognostic. And this study is basically looking at in those individuals who do not achieve a PSA nadir of 0.2 or under, randomizing them at a later time point to the addition of docetaxel to their ADT-RP backbone. So a slightly different question, looking at those unfavorable responders, but responders nonetheless, with a primary endpoint of overall survival. And again, this study has also started enrolling, and they're 2 different studies, but answering very important questions around docetaxel. Okay. All right, so I think what we've all been waiting for, how do you distill this data into making clinical decisions in practice, where you have a patient before you? Like, how do you patient select? What are the things that you think about? And so Dr. Morris is going to take us through the next set of slides.
Sure. Just so a little bit of level setting. I aspire to be Neil Shore in a future life. So I'm a community urologist that with a heavy focus and in a large urology integrated group. And we pair very nicely with 2 large oncology groups in town. So we have a very integrated network, but not in an academic setting. We're not under all one roof. And so these questions probably require a bit more thought in clinic when it's not as simple as like just walk down the hall and go see the content expert in the next room. Yeah. So most of our groups have had to struggle to try to operationalize this data into the real world. So I'm going to moderate this section because I'm certainly not the expert. So I'm going to depend on my wonderful partners here who know all this in and out to basically kind of pull this all together. But I love this, and I've actually used this in many of the decks when I present to other urology groups on what are we using? What are the data points that we use? It's almost like a checkbox list of like, you've got 7 in the yes column and only 2 in the no column. We should definitely go and have you see someone to talk about chemotherapy versus everything's in the no column. And some of it's patient-specific factors. Many of the things on here are tumor-specific factors. And I think the things that are really jumping out at me, other than what you mentioned with the trial, like PSA responses on here as kind of informing the next generation of trials, but also this idea of tissue profiling up front is becoming much more common. I think obviously with amplitude reading out, we're starting to pay attention to upfront screening for not just HRR, but those of us who've been testing for a long time see a lot of TP53 and PTEN loss and RB1, and we realize that there are potentially targeted therapies coming for some of those, but in just the general sense, many of those things are just bad markers. And so I think urologists are even smart enough to say when you get a genetic report back and there's a bunch of things on there, that's generally bad. And they need to go see an oncologist to talk about probably intensifying on top of it. But just the simplest take home is just the timing of recurrence and the volume of disease. That's the easiest thing. And that's NCCN and many things. That's a very clear distinction on who needs intensified therapy. If you have 20 lesions on a PET scan, and that's a whole separate issue that we probably will not get into, but I'd like your input on it. All of this volume distinction is based on conventional imaging. So in a world that we live in today, which is almost every single person that sees me in clinic has a PSMA PET, but does not have a conventional CT scan or bone scan, are you rough estimating what volume of disease is? I've seen some wonderful posters today on nomogram suggesting what is going to be a bad actor or non-bad actor, and they were 20 or above, or 5 to 20 for PET lesions. So there's going to be some cut points that we could probably use. But what are you using in day-to-day practice with PET scans when it comes to volume estimation?
I am not applying the volume criteria to PET scans. And in some scenarios, even though I know it's archaic, I will get a bone scan just to see what I see and to see if the disease is there. But in actuality, not to say the decision is easy, like everybody should get an ADT-RP. And then the question is really around the docetaxel component. And so, there are nuances there even in the volume, like how you classify volume of disease. Like, is it just a bunch of nodes? Is it a bunch of bone spots? Like, so I think there's a lot of gray, if you will. I think we need to evolve our definitions beyond just high and low volume by counting spots on CTs and bone scans, and maybe in the next 5 years we'll move away from that.
Yeah.
Alicia, I'd love to hear from you.
So I often get a CT with IV contrast at some point in the beginning. But I layer in therapy. So I'll start ADT, and a month later I have people come back, and then I start my ARPI, and we're kind of talking about chemotherapy through this time, but somewhere in there I'm also getting CTs with IV contrast. You know, the PET scans don't actually give you great characterization of the liver. And what do we use to follow people with metastatic prostate cancer? We have to use conventional imaging. And so I like to have that in there. Sometimes I get a bone scan. A lot of times I'm like, oh, it's an extra, like it actually is extra time. CTs are so quick. It's so easy to get. And the bone scans, they just, you have to give the dye, and then you have to wait, and then you have to get the scan. So, and also there's so many inaccuracies. So it's painful, but I sometimes order a bone scan too. I will follow with CTs with IV contrast over time, usually every 6 months, maybe every 12, depending on the patient. And then throw in a bone scan every once in a while. But I do get that because I want to have an idea of what the baseline is. And I don't always get it in the first 2 weeks, but I do get it sometime in the beginning. To Raina's point, they're on here. Some of these TP53, P10, as you mentioned, perhaps we'll have some therapies to target this in the future, RB. And there's also SPOP. I'm not necessarily, I am looking for these things. I have not yet foregone chemotherapy for an SPOP, and probably because we all have, you know, our patients that teach us and sort of stick in our head. I had a patient with an SPOP, but he also had a P10. He progressed through a PIS-1 regimen and had passed despite every therapy within 2 years. So SPOP is supposed to be, you know, something that confers sensitivity to hormonal treatments, but in the presence of these other bad actors, I think can be overwhelmed by them. In any event, you know, Raina, what are you thinking about these molecular markers?
You know, I think, and this kind of segues into one of the questions that is submitted by the audience around what's the role of PARP first line. You know, now with the amplitude data and the approval of niraparib abiraterone for BRCA2 mutated mHSPC, every single patient with metastatic hormone-sensitive disease should be undergoing somatic and germline testing. And so I think, you know, we've seen data emerge about PARP inhibitors, and I think the data is consistent that early PARP is better, particularly for BRCA mutated individuals. So it's not a lot of patients. It's going to be less than 10% of individuals, but it really is a game changer for those people. So I think testing is important. And I agree with you, Alicia. It's kind of a staged fashion, right? Like they come in, you're checking on them, you're getting them set up for their testing. It's not going to be back right away. You bring them in, you see how they're doing on their ADT, RP. Maybe you've already checked a PSA. You're getting a sense of what's happening to the individual and kind of strategizing. And I think there's time to work in, layer in the chemotherapy or add in the PARP once their data, you know, comes back. So I agree with you. I think the co-occurring alterations, it's complicated with SPOP, and interesting, again, with Martin's data and what we've seen in the neoadjuvant setting, again, hormone sensitive, the responders have SPOP. None of the non-responders have SPOP, you know.
Yeah.
So the doublet and triplet therapy on here, I think, will quickly be relabeled. And triplet does not necessarily mean DOSI, ARPI, ADT.
No,
Triplet
you're right.
will very quickly become what is your other third partner to ADT, ARPI, and that's fine.
Whether it's lutetium, whether it's PARP, whether it's exactly.
You know, there's other P10 focused things. I mean, there's a lot of things coming that I think the recognition is worse disease, especially with markers, we'll probably need more.
Yeah.
And as long as we tell patients that up front, that like, you know, more is sometimes the right thing. But I agree with you. There are patients that come in wanting more, and it's like active surveillance for localized disease. We almost have to back people off of this idea. Like more is just toxicity, because if you have baseline neuropathy or you have falls at home and you're using a walker and you're frail, like more could be the thing that is bad for you. So it's a bit of a balance act there. So speaking of that, there was actually a great breakout session today dealing with, and this is an elderly patient population, and I have to explain that to some people who are not GU focused. They're like, you know, these are men, often not very healthy and often very old. So they're not the 34-year-old breast cancer patient who may be like gung-ho to do everything under the sun. But I think that we all do this. This is still the 10,000-foot eyeball test of like, are you healthy and fit? Everything's on the menu. Are there certain risk factors in terms of your comorbidity status where we want to think about it but be cautious? Or are you the person that sometimes less is more? And the fascinating story of like monotherapy declining, the question is, what is the right number? Because the right number is not 0. I think for those of us that still see 90-year-old patients, sometimes it's almost like supportive care, that it is a less invasive, less costly. But how do you kind of balance this in your clinic? Is it really an eyeball test? I mean, there's really no labs that tell us easily, like, you do not fit in this category, you don't, other than ECOG and performance status. Those are kinds of eyeball tests in some ways.
And I know, Alicia, you've done a lot of work in the frailty space too. Just like I think we don't really have great instruments for actually assessing like fitness beyond, like you said, the eyeball test, like, which I love because it's so practical. We do that all the time, but.
Well, it's listed here. The G8 is something. It's 8 questions, and if you score on that score, I believe it's lower than 14. You actually have an increased mortality as compared with a hazard ratio somewhere around a 0.6. I mean, it's a substantial increase in mortality. The things on that questionnaire don't take a lot of time, but in a busy clinic, it's really difficult to integrate it. So I do not routinely put that in there myself even. I have colleagues that if I do have a patient who I think is in the vulnerable or even frail area, I do send them to geriatric oncology, which is a luxury, I know, but whether it's a geriatrician or whether it's their primary care, there may be things that can be worked on. So some of the things on the G8 that can be worked on are polypharmacy. So any way that patient can sort of reduce the pill burden, that actually helps. It reduces med interactions, reduces risk of falls potentially. Mobility issues are a huge area that we can intervene. Sending somebody to physical therapy, even though it seems like an extra task and maybe work for them to do, it actually, of course, it doesn't work, but it helps them so much. And I have patients who rave about it. Finally, I'm getting some of this stability back in my gait, and that is hugely important for older adult patients. So these little things, including screening for things like dementia, if you're talking to a patient or family member and they're mentioning that somebody's already forgetting things, losing train of thought, these are screening tests that you can then also send off to other practitioners to help you take that patient from frail or vulnerable and kind of move them into the fit, or at least the better side of the vulnerable. So even if we don't do all of the questions precisely, if we are really listening to our patients and sort of observing what they're doing, we can help and intervene in some of the areas that are actually on these tools.
So, you've gone over the triplet intensification from the efficacy side. This is the trade-off. And I think, at least from a urology clinic in the community, these are the things that we have to run through a television commercial to the patient of like, these are the reasons we don't just give you everything that we can give you. And now I love telling patients that the oncologists are very good at managing these things. This is what they do for a living. So we shouldn't be scared of necessarily all the terms in these boxes because they're manageable a lot of the time, especially if you know what to look for. But there is no free lunch with any intensification of therapy. And I think that it's good to be open with a patient up front because the concerns for them are that they know what their Aunt Ethel had for chemotherapy 20 years ago, and it was miserable. And we often have to explain that docetaxel monotherapy is not 3 different chemo drugs combined. And the profile, although the words are scary, is often better tolerated than a lot of the things that they've had family members get for other disease states. So it's just important to recognize that they're there, and that's why we don't intensify everyone. This is a little strange because it is the opposite question from what we're talking about in clinic, which is what does DOSI add to toxicity? This is what does really the ARPI triplet add to ADT plus DOSI? And the ARPI triplet does increase some toxicity. We don't, and I can't fully explain why neuropathy is higher in a triplet patient population with an ARPI added in, other than just if you're intensifying therapy, it is more treatment for a patient. And they're also on therapy often for longer because of the exposure to the ARPI extends for several years. So hypertension, we do see cardiovascular toxicity with ARPI addition. But in general, most of the things that you would see with docetaxel, you still see them with triplet. and it just looks like some of them are slightly worse. Is there anything on this that jumps out at you? Because this isn't really the question that we ask in clinic. I mean, fatigue, I think obviously 3 drugs is worse on patients than 2 drugs.
Yeah.
But I can't say that there's anything particular other than just the label for ARPIs that we worry about.
Yeah, and I think when I think about docetaxel, when I talk to patients and counsel them around docetaxel, you know, it can be overwhelming when people think about the entire course of, no, you're going to be on therapy for this long, you're going to be on continuous. Like, I try to break it down and like one day at a time. Let's try one cycle. Let's see how you do. We can always walk away. We can always say, no, you don't tolerate it, you don't have to get a second cycle. So I think when you distill it down, when you actually give patients control over the decision and actually put the ball in their court and you say, no, you're driving this show, you want to escalate, we want to give you the best option, but we're timid around side effects. And so I think that helps break things down, because there can be a lot of just overwhelming thought about how am I going to do this. And the thing about docetaxel is it's kind of like one and done. Just 4 months of treatment and then you're done. Then it's behind you. And actually, when you look at the quality of life data, they kind of dip a little bit when people are on their docetaxel, but then they level back out when people are back on their ADT ARPI and kind of coasting. And if you can maintain the period that they're hormone sensitive, where their touch points with you like are spaced out, like the kinetics of the disease and monitoring change in the CRPC setting, like the more you can keep somebody castration sensitive, of course you want to make them live long, actually the better, you know.
This is touched on quite a bit earlier in terms of side effect toxicity profile from ARPIs added in on the individual trials here versus, I think that the high level is most patients are able to stay on full drug. It's about a third of patients have some sort of toxicity from an ARPI where you may have to adjust something and manage something. But there, you can see your discontinuation rates are generally across the board 10% or less, so it's less than 1 in 10. Now, we do a bit of dose modifications, and at least in our clinic, and I'm sure you do as well. But it's rare to have to quit outright because of an AE. And AEs leading to death, obviously horrible. I don't know that we see a lot of those in the real world. Now, in clinic, and at least in trials, things are followed so closely that anything that's possibly attributable to that drug will often be labeled as attributed to that drug. And that could be a heart attack event. Just because of the mechanism of action, there's a concern that that could be due to the ADT or the ARPI. So I think this is probably the most exciting thing that I saw all of the last year at JUASCO. And it's really changed my prescribing patterns, and I'd be interested to hear if it's changed yours, because I think we're going to see this borne out in the utilization rates in 2025 and onward. So looking at and this is, you mentioned earlier, going back to individual patient level data out of the trial. So this is pulling the actual trial data, and this is basically analysis, stop cap across the multiple trials, and at the bottom you can see there, the Stampede did include some where they were actually on kind of quadruple. They were on INZA and ABI, so that's why it says amide plus or minus ABI. But basically, the younger age groups on the top, the older on the bottom, and you can see absolute percentage benefits from being on the drug versus ADT monotherapy. So for PFS, it was about a 25 to 30% improvement in terms of PFS, ABI or the ARPIs. OS, 15 to 20%. And then when you get to the older age groups on the bottom, you start to see a real benefit that persists in the ARPIs, but actually less of a benefit in the abiraterone-treated patients, in the older patient groups. In fact, when you get to OS, at least from the individual patient data from these studies combined into a meta-analysis, really not much of an OS benefit at all if you take a 78-year-old and put them on an abiraterone doublet versus ADT monotherapy. So this has been kind of eye-opening for those of us who used a lot of abiraterone in elderly patients because we felt like it was better tolerated. And I think it's changed our prescribing pattern, at least in the urology clinics that paid attention to this data. There's been a shift in maybe some of those patients to more ARPIs. I'd be interested to hear if that's been your interpretation of this and what's kind of borne out in your clinics.
Yeah, I mean, I think I think it's definitely happened in my clinic. Whether it's conscious or subconscious, I think that this is happening, besides the fact that it is just easier to give an amide because you don't have the prednisone. There are definitely still situations where abiraterone is the drug of choice. So if we're talking about locally advanced, very high-risk localized disease based on STAMPEDE data, then this is where we use abiraterone. If we can't get an ARASENS type approval for a patient who has high volume synchronous disease, we need to use PIECE-1. So, I mean, we follow the labels, or at least I follow the labels that I have when I'm restricted. But when all else is equal, I do think that this affects my prescribing patterns.
Right.
Yeah, I mean, I think this data are like certainly provocative. I think when we do meta-analyses and try to group and dissect the different subgroups and kind of take a look at data in a way that it wasn't intended to be looked at, I think you just have to be really careful. So I think for me, it's certainly paused. I'm like, okay, I have an older adult. Like, do they have cardiovascular tox? Do they have AFib? Have they had, a cardiac event? And that could, certainly come into play. But it's certainly not a blanket, oh, you're over 75, you're not getting Abby in my clinic. I think it's basically a pause. And I think as we think about drug development and what's coming down the pike, there are a lot of combinations of therapies that are being paired with different kind of drugs, like whether it be Enza, whether it be Abby. And I don't think restricting around that is going to be something that we should do.
Better said than me. I think it's more it's still a good drug. It's just maybe I don't reach for it preferentially.
Yeah.
And it's more of well, maybe I should view these equally in that sort of older patient population. This is as you mentioned earlier, kind of the P scales of saying like more intense therapy is potentially better in terms of efficacy. So this is really efficacy data. And it shows even in those older patients, triplet potentially has more efficacy. Now, obviously, that may have more of a toxicity trade-off in those elderly populations. So it's not necessarily a slam dunk that just because the numbers are higher for their P-score that that's the therapy they should be getting. But I guess it is effective in older patient populations, that they still have benefit of chemotherapy despite age. And I think age obviously is a number, it's not a functional measure, it's just an age. And then this is probably, from a urologist standpoint, we unfortunately are so PSA driven with localized disease management that this has really been interesting to see this kind of bleed into our treatment selection as we get to metastatic disease. So you mentioned Ironman. This is obviously a registry, international, and you can see here measuring kind of PSA responses. There's a limited subset of triplet patients, so this is not really built on a triplet patient population, but really looking at doublet patients and PSA responses and looking at the percentage of patients who have a disease relapse or a PSA progression at certain time points. And this is patients who've had basically a kind of freedom from relapse. And so if you're looking at overall ADT monotherapy and then the combinations at the bottom, whether it's ARPI or docetaxel, basically within those treatment buckets, if you had a PSA response that nadered under 0.2, you had a much higher chance of being free from recurrence at the 12, 24, and 36-month mark versus those who did not have a PSA that nadered. So this is kind of really informing the kind of plan for like triple switch is like if you are in this ARPI bucket and you don't get a response, you're probably headed towards needing docetaxel in the near future anyway or something else. Why not just give it up front before you potentially have had a decline in your performance status? So outside of a trial perspective, are you using anything like this in clinic yet? I mean, it's not really in the guidelines, but are you following them more closely? Are you counseling them ahead of time if you don't have a PSA decline? Like, I'm more nervous about you. What are you doing differently? Anything at this point?
Not necessarily doing something different, but it does set expectations for me. And when I see that somebody's PSA is slow to decline and really kind of like stagnating, I'm scanning them more frequently. I'm getting imaging on a regular clip. I'm starting to lay out the groundwork that may change something. So when I do change, the patient's not shocked and it's out of the blue, but my PSA is doing so great. So I'm like, you always say like the lower it goes and the faster it gets there, the better. Like you're still doing good, things are declining. But I want to set up plan B, C, D, E for you. Like, so beginning to kind of like get patients ready for when you're going to change or switch, I think is really important.
I completely agree. If you give people a number that they have no control over meeting, I think that's a challenge for them. So I do exactly the same thing.
This is kind of, we've been speaking on the left side here, which is consider escalation in those patients who don't. A whole separate category, and we've seen several presentations and their trials in progress on the other side, which is if you do have a great response, is this really something I have to be on, doc, for the next 5, 10, forever years? And obviously that is an unanswerable question at this moment, but I think stay tuned. Obviously there's a lot of interesting data on de-escalation just as much as there is on intensification on the front end. So
I will say there is a phase 2 study through the cooperative groups called A-DREAM that was led by Atish Chowdhury. It will be reporting out sometime this year that did just very that. For those exceptional responders that got to a PSA undetectable after I think like around an 18-month period, and they were allowed to discontinue therapy and were followed for PSA relapse in the context of testosterone recovery. And so I think that we're going to start to see some emerging data about could there be a subset of patients where you can safely potentially de-escalate, but more to come on that.
This is, I don't know that I love this because it's pitting urologists and oncologists almost at odds on saying what is the most important thing, which is kind of a silly way to ask it, but I'll blame Steve Friedland. So this is basically a survey saying what reduction are you looking at, and what is your importance level for trying to meet that goal? And if you had a higher PSA reduction that you were shooting for, you tended to be more aggressive with your intensification, which makes sense because people who are shooting for a higher target tend to be more aggressive on trying to get there. So basically anybody in the 75 to 100%, like that's my PSA reduction goal, they were much more likely to be intensifying both in the first line and in the first line any subsequent line. But I think generally, whether you're a urologist or oncologist, we shouldn't be shooting for less than 50% decline in PSA. We want to see more than a 50% decline in PSA. And so I don't like these that set up different specialties against each other.
Yeah, no,
but
totally.
urologists are probably more focused on PSA just because that's literally like what we deal with on a patient-stimulated anxiety day in and day out. Physician-stimulated anxiety also. So, the last session there was a lot of discussion about access. Thankfully, with pill access and chemotherapy access in most clinics, we have access. This is not an RLT where we're having to deal with authorized users and access where we can be made and distributed to. But this is basically saying in some resource-constrained settings, which hopefully would not be many locations in the U.S., but could happen from northern Maine, getting shipped down to Boston for specialty care.
Yeah.
I'm in the South, and we have patients who live 2 hours from what you would consider a reasonable medical community to get care. They're basically saying like, the best may be triplet, but in some resource-constrained areas, or if the patient can't afford it or can't get access to the pill, then maybe doublet would be a chance. And doublet with docetaxel just because it's a generic medication, which tends to be cheaper. But I would say that's not really the guidelines. And you guys made that very clear during the intro that unless there's a reason to be doing ADT plus dosi as alone, almost everybody in the U.S., we should be striving to get on an ARPI. And it's fascinating to learn at this conference about ex-U.S. patterns because honestly, it seems like most places that I hear from outside the U.S. physicians, they actually have sometimes better access to ARPIs than we do in the U.S. just because of their institutional standards across their countries in terms of access. This is looking at the U.S., and this is looking at both community and academic setters, and really saying, there are many things in our communities that can direct patients to be able to achieve these sort of intensified therapies. It's always important when you look at geographic variation. And I'd like to, in the Southeast, we'll point out African American men because they're underrepresented in our trials, but often overrepresented in our clinics. And so it's always intriguing to look for that patient population. If you see 25% African Americans in your clinic and the trial says 5%, you need to pay attention and see if you can find a data set that has something closer to what you see in your own clinic. And you can see your ADT monotherapy in this over almost 2,000 men was about a little over a third of men getting ADT monotherapy. And then they were looking at what were the things that kind of suggested you were more likely to get doublet therapy and potentially less likely to get the monotherapy. And region is certainly one of them. There's a lot of geographic variation in terms of where patient care is delivered, what access to care patients have. Down at the bottom, you'll see things like urban population, which can explain a lot of variation. Obviously, in Boston or San Diego, there's a lot of access compared to the middle of Kansas, just depending on the density of physicians in that area. Urologist density and radiation oncologist density and the radiation oncology density, it's like the opposite of urologist density. I always find that intriguing from this. But it's almost like radiation oncologists don't tend to operate on an island. They're usually in kind of integrated systems that can help support them. And so they usually have medical oncology right next door. They often are in tertiary centers. And so I think that's just a measure of the complexity of care that can be delivered in that community. So just having a community urologist is not enough. If you've got a radiation oncologist, that means that you've probably got a pretty integrated network that you can get patients in to get kind of triplet therapy if needed. So I guess that's it. Raina, I'll turn it over to you.
No, thank you so much. This has been really awesome discussion on metastatic hormone-sensitive prostate cancer and really where the field has come with the clinical trial data and then actually distilling that into clinical practice. We do have about just a couple of minutes for questions. Actually, we've addressed many of the questions that you all have had around, avoiding ABI for people over 75, which we've addressed. What do you do when you hit a PSA of 0.2 at 2 years? Do you stop? Currently, I think we chatted a little bit about that. I don't know if anybody has anything else to add around that.
I'll probably like you, I'll often lean on the guidelines say this, but it is your decision. Like you said, it's your decision to get one dose of chemo and say you can't do any more. I will say it's your decision, and understanding that it may put you at risk. If that is a risk that you are interested in potentially taking, I'm here to help you manage what time you have left. And if you want to do that, then that is for you. Because some people say that it's worse to be on these drugs than it is to live another year. So it's a challenge for some patients.
Yes.
All right. Great. So just want to highlight. Sorry.
Good evening. No, wonderful talk, especially after a long day. Like a lot of regards for sitting up and pulling this off. But technically, when we talk about ADT versus ARPI, so the most brutal treatment initially, as from a derivative standpoint, was orchidectomy, taking off the testes of a patient, and because we don't want any male hormones, no androgen. It's just technically a hormonal disease that we're dealing with here. Because so when we are interfering with the hypothalamic pituitary axis and then the adrenal glands, we're interfering with the ADT pathway. And when we're directly blocking the receptor at the level of the cancer cells, we're talking about ARPI, ENSA or DARA or whatever. We're just directly targeting the receptor at the cell or the surface of the cancer. The data you showed in older groups was mind-blowing. I haven't seen something like that before, that only the ARPI worked tremendously and ADT didn't have that benefit. Especially when you're talking about the data you just showed me was in the elderly age group. There's something about the surface receptors that seems to be responding better than the entire hypothalamic pituitary axis. I'm getting more and more confused with what we're doing with prostate cancer, to be honest. And I just want a refresher from your standpoints. As to how to approach this entire hypothalamic pituitary blockade, hormonal shutdown, surface receptor blockade. Chemo reduction is something which is something else altogether. We're just shutting down the replicating cells, and that's just toxic chemotherapy, which is just something else altogether.
So I'm happy to take that on. So just to kind of repeat, the question was really focused around what do you do with the ADT, and there's different formulations of ADT. And just for clarity, as we're talking about all of this data, everybody is on ADT. Everybody is on androgen deprivation therapy with a GnRH analog, whether that analog is an antagonist or an agonist. All of the data that was presented today is under the presumption of continuous ADT. Abiraterone is a synthesis inhibitor of testosterone production in the adrenal gland, and the other three next generation antagonists basically block at the receptor, but that's in combination with ADT. So there's a lot of different formulations of ADT. We're not going to get into that. Certainly for those individuals that are in a resource poor scenario that have high volume metastatic disease, orchiectomy is a perfect treatment for them. And then you don't need a GnRH analog because you've done an orchiectomy, and you can layer in whatever RP you select in that context. So I know it's confusing. Happy to talk offline around the different formulations of ADT that can be used, but this is all under the presumption of continuous ADT. Any other questions from the group? With that, I want to make sure we finish on time. Thank you so much to our esteemed panelists, and thank you all for sticking it through. 9:30. Hopefully you can get some dinner, get some dessert, drink, and we'll see you tomorrow. Thank you.